Good afternoon, everyone. This is Deborah Hodges. I'm with the Institute of Medicine of Chicago. I welcome all of you here today for our webinar presentation, From Awareness to Action, Increasing HPV Vaccine Referrals in Dental Settings. I have been with the Institute of Medicine of Chicago since 2019 and very honored to be part of this organization and participate in a small way as their association manager and as their program manager. So let's just orient everyone to what's going to take place today. After our welcome, we'll tell you a little bit about the Institute. We'll talk a little bit about upcoming programs, just a few advertisements before we start the presentation. And then we'll go into a question and answer session, and you'll be able to put your questions in the Q&A box. And also, if you list any in the chat box, I'll try to also pick those up for you. So to give you an overview today of what's going to take place, the HPV is the most common sexually transmitted infection in the US, and it's responsible for over 70% OP cancers. And the HPV vaccine can prevent these cancers. So we're very fortunate to have a very accomplished speaker with us today. Dental providers can provide and address this public health concern through regular organ examinations, patient interactions during their critical vaccination periods, and also building a trusted relationship. However, many lack confidence discussing the HPV cancer link and the vaccine referral. So today's attendees, you're going to learn how dental teams successfully incorporate, educate, recommend, and refer approach into your daily workflow, transform routine dental visits, and cancer prevention opportunities. Today's learning objectives are we'll describe the epidemiology of HPV-related oropharyngeal cancer and the preventative role of HPV vaccination across healthcare settings. You will also recognize how interprofessional approaches can expand opportunities for HPV vaccine education and referrals beyond the traditional medical settings, and identify strategies for strengthening collaborative networks to support comprehensive HPV vaccine efforts in your own community. With us today is Dr. Jennifer Zukalski. She's an assistant professor with the University of Iowa. She's in the preventative and community dentistry area. Her work specifically addresses OPC cancer rates, and Iowa has the distinction of having the nation's most highest rates. This will be explained through two complementary research areas that she has been involved in. More details from her specifically. She's the expert, not me. And as both a registered dental hygienist and a researcher, she bridges the clinical practice and the implementation science to develop patient-centered interventions that improve cancer prevention and cancer delivery. So we're delighted to have her with us today. Before we begin the actual presentation, let me tell you a little bit about IOMC, especially if this happens to be your first time attending any of our webinars. The Institute of Medicine was founded in 1915. It's an independent 501c3 profit organization. It is composed of distinguished leaders in the health field who collaborate to improve the health of the public. The organization draws upon the expertise of its diverse membership and other regional leaders and addresses critical health issues through a range of interdisciplinary approaches, including education, like today's program, research, which also is included in today's program, communication of trusted information, and community engagement overall. Our fellows are comprised of clinicians, doctors, dentists, pharmacists, nurses, lawyers, advocates, academic leaders, hospital leaders, industry leaders, and executives. Everyone is dedicated to driving meaningful change in the workplace itself and in the public health environment. If you're interested in becoming a fellow, it is open to all. Please contact us or see our website for more information how you can apply. So there's a QR code here that you can copy, and we'll also make that available to later on in the presentation itself. I wanted to bring to your attention a deadline that's coming up this week on April 23rd. It is for our 2026 Leadership Awards. All submissions are due by the 23rd itself. The recipients of these awards will receive their honors at the June annual meeting, which I'm about to tell you about, and that'll take place on June 25th. And our keynote speaker is Dr. Aaron Sousa, which we are very proud that he's able to join us. He is the new president of Rosalind Franklin University of Medicine and Science. So registration is open for that event. It's open to all. On the average, we have about 175 to 200 people who attend that event. It includes networking, keynote speaker, as I mentioned, with Dr. Sousa, a nice dinner, lively spirits, and ample networking time to meet with others. So we hope that you'll find time in your calendars to join us. The last item that I want to mention before our presentation starts is to check out our Career Job Center, which has over 5,000 jobs listed. So if you're looking for your next career destination and challenges, this is the place to visit. That you do not need to be a member or a fellow of IOMC in order to be able to use that job center. It's free to all. You can post a confidential search so that they'll come directly to your inbox and bring you many opportunities. So right now, at this point in time, I want to turn this over to Dr. Sokolsky at this point in time. Thank you so much for being with us today. I'm sure everyone's looking forward to your presentation.
Thank you, Deborah, for the nice introduction. And thank you to IOMC for the chance to speak with the group today, because I'm excited to talk about what we're doing in the state of Iowa. As Deborah mentioned, my name is Jen Sokolsky. I'm at the University of Iowa. And over the next hour or so, I want to talk to you about cancer prevention opportunities in the dental office. So I'll walk you through why HPV-associated cancer is a growing health problem, what we know about the vaccine, and why dental teams are uniquely positioned to move the needle on the vaccination rates. And I'm going to share with you what we're currently doing in the state of Iowa. And hopefully this will pique some interest of those in the audience and, talking about medical dental integration. This is definitely a team effort. It spans two colleges here at the university. So our PI is Dr. Natasha Askelson out of the College of Public Health. I'm at the College of Dentistry. And then we have community partners. So Elizabeth is our community engagement individual from Iowa Immunizes. And this team, nothing would be possible without the team. Next slide, please. And the work I'm sharing today has also been funded by the Holden Cancer Comprehensive Center with support from the National Cancer Institute. We also currently have a CDC-funded grant from the Cancer Prevention and Control Research Network, the CPCRN, and the pilot data that I'm going to share with you today was funded by the Roy J. Carver Charitable Trust here in Iowa. So the pilot data and all of this intervention component that I will talk to you about wouldn't have been possible without this multi-source fundings. Next slide, please. So first, let's ground ourselves in the basics. We'll talk about what is HPV, how common it is, and what it does. Next slide, please. So HPV, or the human papillomavirus, is a viral infection that infects epithelial cells. It's transmitted primarily through skin-to-skin contact, most commonly sexually transmitted, but we do also see non-sexual transmission pathways as well. There are over 200 identified strands or types of HPV, and the vast majority cause no clinical problems at all. But we do have 12 types that we classify as high risk, or they've been classified as high risk, because these are the ones that are most often associated with cancer. So HPV-16 and 17 are the two biggest concerning strains. HPV-16 is particularly responsible for about 70 to 90% of HPV-associated oropharyngeal cancers and 60% of cervical cancers. And HPV-18 is most prominent in cervical cancer. Two things to emphasize here. First, infection is usually asymptomatic. So most often people will transmit HPV without knowing that they're infected. That's part of why it spreads so efficiently. Secondly, you can be infected with multiple types of HPV strains at the same time, so it's not a one and done exposure. And people can acquire a new type of each new infection, so the risk is cumulative over the lifetime. Next slide, please. Most HPV infections do clear on their own, but usually within about 2 years. The immune system typically handles it, so no cancers, no warts, no clinical consequences. That's true even for our most high risk strains, HPV 16 and 18 as well. Their bodies mount, and our bodies typically have the immunity to fight that off. But when the virus persists, especially when it's one of those high risk strains and the body doesn't clear it after those 2 years, that's when we get concerned. So at a cellular level, the persistent high risk HPV integrates into the host cell's DNA. And this disruption is what drives the transformation to cancer over time. And that over time is key. The latency period between HPV infection and HPV associated cancer is long, anywhere from 10 to 30 years. Someone exposed in their late teens or early 20s may develop cancer in their 40s, 50s, or 60s. And we can't easily predict which individuals will have persistent HPV that will persist into or progress into cancer. And we don't have a good screening test for all HPV associated cancers like we do for cervical cancer with our pap smears. Next slide, please. The scale of HPV infection is great. It is estimated that around 42 million people in the US are currently affected, or 13 million, and it's estimated that there's 13 million new infections each year. The age distribution of infection also matters. So peak HPV incidence is in the late teens and early 20s. That's why vaccination, which we'll talk about scheduling in a bit, but vaccination early is an optimal strategy. So put the lifetime exposure into perspective, it's estimated that roughly 80% of adults will acquire at least one HPV infection in their lifetime, so about 8 out of 10. Next slide, please. Now, I want to shift from HPV specifically to cancer more broadly, because this is something that Iowa is currently, we have an issue with, I should say, as Deborah alluded to. Iowa ranks number 2 in the country for age-adjusted cancer incidence, number 2 behind Kentucky, and I will say we oftentimes battle it out for number 1 depending on the year. Iowa is also one of only 2 states in the entire country where age-adjusted cancer incidence rates are rising. The rest of the country is typically falling flat, or plateauing or dropping, but Iowa is going in the wrong direction because we are increasing. This is an area of active research for us here at the state of Iowa. We're trying to understand the why. Leading hypotheses that we have at the state, and I should mention that I have a lot of work with partnerships with individuals who work within the cancer space outside of head and neck cancer. But leading hypotheses include high rates of alcohol use. We in the state of Iowa have some of the highest radon exposures in the country. We have substantial agriculture, chemical exposures, obesity rates, tobacco burden, aging population. But really part of that answer, and one of our focuses for this project is most certainly our HPV-associated cancers, which I'll show you in a minute. But the full picture is multi-causal, and we don't really have it fully figured out yet. But this project that we'll chat about is just one piece of the pie. Next slide, please. This chart makes the point visually. This is a time frame from 2010 to 2022, so we're looking at roughly a decade of data. The yellow lines are Iowa, crude rate on top and age-adjusted below in the solid line, and the teal lines are the US. And you can see the Iowa crude rate climbing steeply and the age-adjusted rate climbing moderately, while the US adjusted rates are essentially flat with a slight increase on our crude rates. So this is telling us that even though we're adjusting for age, Iowa's cancer rates are still diverging from the US cancer rates here. Next slide, please. What most people hear when we think about HPV is we think about cervical cancer. But I like this graphic. It's just the tip of the iceberg. There's so much more to HPV-associated cancers. HPV does cause cervical cancer, yes, but there's also oropharyngeal cancer, which is cancer of the tonsils, the base of the tongue, and the throat. It also causes anal cancer, vulvar, vaginal, and penile cancer. Altogether, about 36,000 HPV attributable cancers are diagnosed in the US each year. It's roughly 19,000 oropharyngeal cancers diagnosed, mostly in men, and in about 11,000 cervical cancers. The the headline or the takeaway that I want everyone to come away with today is that oropharyngeal cancer has actually surpassed cervical cancer around 2015 as the most common HPV associated cancer in the US, and it disproportionately affects men, as I mentioned. Roughly 82% of HPV associated cancers, oropharyngeal cancers, are in men. And there's one more point that matters for prevention. As I mentioned before, cervical cancer has screenings. There's no formal way to test for HPV-associated oropharyngeal cancers. There are some products that are currently underway or being studied in terms of saliva testing and so forth, but nothing that's public and no way that we can necessarily look at that currently. That's why primary prevention or vaccination is so critical for oropharyngeal cancer, because we can't really screen for it, but we can prevent it. Next slide, please. Taking a step back with oropharyngeal cancers, here's what it looks like in Iowa and why we are so concerned. So the yellow line is all oral cavity and pharyngeal cancers, and it's rising. And it's rising faster than other cancers or national cancers, which are the dotted lines. If we look at the two lines below that, the orange line is non-HPV linked oral and pharyngeal cancers, and it's relatively flat. So Iowa is the solid line, US are the dotted lines. But the blue line, that is HPV linked oral pharyngeal cancers, and it is climbing steeply. So that is what's driving Iowa's head and neck oral pharyngeal cancers in the state. It's that HPV driven cancer. So we're seeing this rise of OPC associated with HPV, and we're seeing it at a faster rate than most of the country. Next slide, please. I did want to touch on Illinois since I know that I'm talking to IOMC. This is OPC rates in Illinois over time, and you'll see the pattern here mirrors what we're seeing nationally. If we look at the two lines, men are in black, women are in yellow. Male OPC cases have climbed dramatically since the late 1980s, from around 30 cases to roughly 60 cases annually. And female cases have stayed relatively flat. So this is a striking sort of sex-based disparity here. One of the reasons for this, if we're thinking about it nationally, the vaccine was rolled out in 2006. I'll talk about this a little bit more in a minute, but it was traditionally rolled out and targeted towards young female as a form of cervical cancer prevention. But now we're starting to see our female HPV rates are staying flat, and we're seeing an increase in our male associated rates. So the male to female ratio is roughly 4 or 5 to 1. And again, the focus typically around HPV vaccination is young females, but we're trying to change the narrative on there and really target vaccination for all. All right, next slide, please. Zooming in further, this is Cook County specifically. The same male predominant pattern hold here. The black bars are men, the yellow bars are women. They're grouped in 5-year time periods. And every time period, male OPC cases run roughly 2 to 3 times higher than our female cases in absolute numbers. In the most recent 5-year window, the 2018 to 2022 shows the highest totals Cook County has ever recorded, with over 2,200 male cases in that 5-year period to roughly 1,000 female cases in that 5-year period as well. So we're still seeing consistent trends in Illinois and Cook County as we are in the state of Iowa. Next slide, please. So we have this growing cancer problem, but we also have a vaccine that can help prevent it. This chart shows up-to-date HPV vaccination coverage among 13 to 15-year-olds in Illinois. And I want to draw your attention to a few things. So Chicago specifically is a solid black line, and it does actually reasonably well. It's hovering around the 60 to 75% range, and that's better than the US average. which is that dotted black line. But the rest of Illinois, the gray solid line, is meaningfully lower with around 50 to 60%, and the national average is around that 60%. Healthy People 2030 has a national goal of 80% vaccination coverage nationally. Nobody is near hitting this, I want to say, but that is the ultimate goal for us. So the gap between where we are and where we need to be is substantial, and that's true whether you're looking at Chicago, Illinois, or the rest of the country as a whole. Next slide, please. But as I mentioned, we have a vaccine for that. The vaccine can help to prevent more than 90% of HPV-associated cancers. Gardasil 9 is the only US FDA-approved HPV vaccine here in the States, and it can help prevent against 6 HPV-associated cancers. Again, as I mentioned, cervical, vulvar, vaginal, anal, and oropharyngeal cancers and other head and neck cancers. It can also help to prevent genital warts later in life by targeting those 9 strains. So the strains that they target are 6, 11, 16, 18, 31, 33, 45, and 52. And as I mentioned, 16 is sort of the one that's most often associated with cervical cancer, but also head and neck cancer. It is also recommended that the vaccine starts as early as age 9 up until the age of 45, and it is proven to be safe and effective. Next slide, please. So since its introduction in 2006, there's been over 270 million doses of the HPV vaccine that's been administered worldwide. This is one of the most robust safety records of any vaccine that we have. In 2017, scientists reviewed all available data on HPV vaccine safety and found 109 studies with about 2.5 million people from 6 different countries. They found no unusual patterns or clustering of serious adverse effects for the HPV vaccine. The most common side effect is what you would expect from a vaccine: injection site soreness, mild fever, occasional headaches, but serious adverse events were extremely rare and not causally linked with the vaccine at any rates above background. Next slide, please. Furthermore, when we look at nationally representative data, looking at 3 years prior to the vaccine rollout in 2006, so this is looking at NHANES data from 2003 to 2018, we saw that there was an 88% decline in HPV infection among teen girls, so that's 14 to 19-year-olds after vaccination. And then we saw an 81% decline of HPV infections in young women, so 20 to 24 are age 20 to 24. Next slide, please. In a randomized control trial of 15,000 Finnish females, they randomized the HPV vaccine and completed a follow-up 11 years later. In the vaccinated group, after 11 years, they found that there were 0 cases of HPV-associated cancers. However, in the non-vaccinated group, there were 17 cases of HPV-associated cancers. Next slide, please. Scotland started its vaccination program, I believe, in 2008. Researchers followed that cohort, about 400,000 women, and looked at cervical cancer rates as a function of vaccination status and age at vaccine. And the big finding was that among women who received at least 1 dose at ages 12 or 13, they found 0 cervical cancers had been diagnosed in that follow-up. Not reduced, but had been eliminated in that cohort at the age of vaccination and during that followed-up period. Next slide, please. Which brings me to timing. I've sort of alluded to differences in timing and the start period being around 9 years old. This is Swedish data. So they looked at 1.5 million women, they followed them over many years. Women vaccinated before the age of 17 had an 88% risk reduction of invasive cervical cancer. Women vaccinated later had meaningful protection, but not nearly as strong. So why does the the timing matter? Why does vaccination earlier work better? There are two main reasons. One of the first reasons is being about exposure. I mentioned earlier, we want to vaccinate long before anyone is ever exposed. HPV vaccine is meant to be prophylactic, not therapeutic, so it prevents the infection. It doesn't clear an existing one. So vaccinating before the first exposure is key, and that's when the vaccine is allowed to do its full job. The second reason is immunologic. Younger adolescents mount a stronger antibody response to the HPV vaccine than older teens and adults do, which is also why we see differences in scheduling and dosage. So the current scheduling dose for adolescents, 9 to 14-year-olds, is a 2-dose series. After the age of 15, 15 or above, I should say, it is a 3-dose series. And this just has to do with how the body responds to the vaccine itself. So earlier vaccination produces a stronger immunoresponse, requires fewer injections, and protects the patient long before they're ever exposed. Next slide, please. And now the piece that matters most, I think, for me in terms of oropharyngeal cancer prevention is one of the studies that looked at vaccination and HPV-associated oropharyngeal cancer prevention. So a US study of nearly 3,000 adults found that receiving at least one dose of the HPV vaccine reduced oral HPV infections by 88%. So that's essentially the same effect size that we see for cervical HPV, but in the oral cavity. And I do want to mention in June of 2020, Merck, the manufacturer of the HPV vaccine, was granted approval by FDA, the Food and Drug Administration, to say that the HPV vaccine could be used to prevent oral pharyngeal and other head and neck cancers that were caused by HPV types. So this request to add HPV-associated OPC prevention really accelerated that approval, meaning that FDA gave approval based on the clinical evidence that the vaccine does help to prevent oral HPV infections. So this was something that I would say, as healthcare providers, dental providers that sort of worked in this space, we hypothesized that this was the case, knowing that HPV strain 16 were so closely linked with head and neck or oropharyngeal cancer and cervical cancer, and seeing the strong response of HPV cervical infections and cancer rates declining with the vaccination, we hypothesized for a long time that this would also be the case with oropharyngeal cancer. And among the results and the studies that were completed, we are now able to say that it is an oropharyngeal cancer prevention tool. Next slide, please. So we have the cancer problem and we have an effective vaccine, and there's growing recognition that dentistry plays a role in getting the vaccine into individuals. So the ADA, the American Dental Association, has been explicit about this since 2020, when FDA provided their approval. So the ADA policy urges dentists to support the use of HPV vaccines, specifically notes that dental offices are an additional point in which we can advocate for patients to follow immunization standards. And it goes further. It says that with state legislative approval and added training, dentists could actually administer the vaccines themselves, not just recommend it. There are some states that do allow for HPV vaccination from dentists. So this is a significant shift for most of modern dentistry. I would say, vaccines weren't necessarily always in the conversation, but as I mentioned, there's a growing number of states that do allow vaccination from dentists, Illinois included. Illinois allows for dentists to provide vaccines for influenza, I believe, but as I mentioned, some states do have a wider swath of which they can administer vaccinations. So more and more states are looking into authorizing dentists to be able to administer certain vaccines. The workflow, the infrastructure, the billing codes, all of those pieces have to come together for that to happen in certain states. But the question really is no longer, should dentists or dental teams be involved in prevention, HPV prevention? The question is, how do we train and equip them to do so and to do it well? Next slide, please. I do also want to point out the American Academy of Pediatric Dentistry issued a similarly strong statement, and it was updated in 2024. Their guidance is very practical. They provide they are providing providers with guidance on how that they can do this. So one being educating parents and patients on the HPV vaccine, and on the consequences of HPV, the relationship between HPV and oropharyngeal cancer. Two, they talk about counseling patients and parents on HPV vaccination using CDC's recommendations. Three, routinely examining signs for OPC or of OPC. They also strongly encourage their providers to follow current literature because, as you can imagine, in the space and in dentistry and science in general, things are constantly evolving and changing. And then five, consider incorporating other HPV prevention approaches into their practice. So it's a pretty comprehensive ask, and it aligns perfectly well with what we've built into our intervention, which I'll show you in a few minutes. But I do want to highlight that professional organizations within dentistry are on board with this and are in support of this, and are really moving to push the needle into prevention of oropharyngeal cancers. Next slide, please. But here's where the problem sits for us in Iowa. Now, I've showed you vaccination rates for Illinois. I'm going to mention Iowa because this is really what got us interested in it within our state. Up-to-date HPV vaccination coverage for 13 to 15-year-olds is what I'm showing you here. Teal is the US or US trend, and yellow is Iowa. You can see Iowa peaked around 2022 with about 73%. So we were above national average. But look what's happened since. We've starting to fall back down to the national average and now below that. We're going in the wrong direction. And this is at the same time that we're seeing oropharyngeal cancer incidence rates in the state of Iowa climb. So this is one thing that we think that we can help to prevent long term. Next slide, please. And I do want to mention that state average does obscure variation. Iowa is pretty rural state. We have some counties that have additional challenges or barriers to HPV vaccination. So here we can see a county map. This shows complete HPV vaccination series coverage for 13 to 15-year-olds across Iowa's 99 counties. The darker counties mean higher vaccination rates. The lower means lower. And the range is striking. It goes from anywhere from about 21% on the low end to about 69% on the high end. So with one state alone, we have a threefold difference in HPV vaccination depending on what county the individual lives in. And as I mentioned, geographic disparities like this are a mix of different challenges, provider access, maybe school-based immunization programs are in some of those more rural counties. Community norms play a role, and also local vaccine hesitancy. But what this means practically is that a statewide strategy has to include all-encompassing rural communities and lower coverage or lower vaccination rate counties. And that's hard, I will say, when we're working with communities, because at times too in some of these areas there's fewer pediatricians, fewer primary care physicians, or even fewer public health clinics that we can access and call upon. But I'll chat a bit more about that with us later. Next slide, please. So why dental? I will say dental providers are already experts in prevention. Dental hygienists and dentists do oral hygiene instruction or oral hygiene screening at every appointment. We do oral cancer screenings. So I teach with our first year predoctoral students. One of the very first things that we do in the clinic is teach them a head and neck assessment looking for signs of oral cancer, not necessarily HPV associated oral cancer, but all signs of oral cancers or different lesions that we may be seeing in the patient's mouth. So this is very near and dear to my heart. But we do that at every recall. We're assessing gingival tissue. We do an oral health risk assessment, a caries risk assessment. We're looking at and talking with patients about diet and nutrition and how that impacts their oral health and also systemic health. And we talk about tobacco cessation counseling, and that's been a part of all of those activities have been a part of dental practice for decades. So when I was brought into this project, it just sort of felt like a natural fit and flow. Another thing that's often missed is adolescents oftentimes see the dental team or go to the dental office more often than they're seeing their primary care physician. Many adolescents and teens, if they have a dental home, of course, there's additional challenges, but if they have a dental home, they may be seeing their hygienist and dentist for cleanings twice a year, but only seeing their primary care physician once a year, if that. So this is just another access point and opportunity that dental teams have to be a part of HPV vaccine champions. Next slide, please. One of the common objections that we hear from dental providers is that they feel as though parents may be uncomfortable if they bring up this topic, but the data does say otherwise. So this is a nice study from Stoll et al. Up in Minnesota. This was around 2020. They surveyed parents on their comfort with dental-based HPV conversations. This is a fun study. They did it at the Minnesota State Fair and chatted with parents as they were coming through. But ultimately, what they found is that 90% of dentists or parents felt that 90% of dentists can help prevent HPV mouth and throat cancer. 86% of parents expected their child's dentist to talk to them about the HPV OPC link. 81% were comfortable with dentists recommending the vaccine, and 83% were comfortable with that, and 81% expected their dentist to be interested in their child's HPV vaccination status. And when I present that information to some of the dental offices that I work with, they're surprised by those results, but also encouraged with these conversations that we're teaching them to have. So parent comfort numbers were consistently between 80 to 90% range. So parents were not just willing to have the conversation in the dental office, but they were expecting it. Next slide, please. So I'm going to get into the project that we're working on now. About 8 years ago, our team started asking the question, what if we're going to build if we were to build an intervention for dental teams, what would that look like? How would that work and how would that fit into their day? And this is actually when I got pulled in. At the time as Deborah mentioned, I'm a dental hygienist. I was working in private practice, so I had quite a bit of private practice experience, and we really wanted to develop a training program where we could roll out an intervention that worked within a private practice setting. So we did formative research. 20 dentists were interviewed, 20 dentists in Iowa, 19 hygienists in Iowa, and then we surveyed 470 hygienists across the state. And we asked them, where would this fit in their appointment? What do you need to be comfortable in having these conversations? What would make you not do it? What came out of that was our intervention, educate, recommend, and refer. These are 3 steps that map onto what the dental team already does within their current practice, but we're just modifying it for an HPV conversation. We also pilot tested this training, educate, recommend, and refer, as a webinar version. So as you can imagine, about 8 years ago was pre-COVID. Then 2020 was when we were initially going to start rolling this out. We had to pivot as we all did during that time. So we piloted this as a webinar with dental professionals across the state from different FQHCs. And it went really well. We had strong course evaluations, 94% reported gain in knowledge, and we're really excited and wanted a hands-on component. We then also provided an in-person session in rural Iowa, Southwest Iowa, with about 48 dental professionals as well. And that was a slightly modified version, but that was our first time doing it in person. So again, overwhelmingly positive feedback from those individuals. Next slide, please. And from there, we developed our sort of final, I hesitate to say final because we continue to modify as things change. But we developed sort of the core of what educate, recommend, and refer is. The final training that we currently have is a 3 1-hour session. Each session combines direct instruction with hands-on activity, and we have a role-playing activity. We talk about common scenarios and talking through kind of sticky parent responses. So the first 1 hour session is on the science. So a lot of what we talked about today, even. What is HPV? We talk about the vaccine, safety and efficacy, and the link between HPV and oropharyngeal cancer. So we think about we sort of take the information that dental providers have and the existing knowledge within head and neck space, and we expand it to HPV and HPV vaccination. Session 2 is the communication piece. We provide them with evidence-based techniques for talking with parents about the vaccine. So part of my team, Natasha Askelson, she is a community and behavioral scientist. She's got amazing experience within communication, and this is where she really helped to pull together what those products look like. And this is where we really build the conversation. We give them different questions, and we ask. It's interactive. We're asking dental providers what questions they're expecting from parents, and we work on how could we respond to those. And then session 3 is really developing a protocol within their practice and building it into their workflow. So in the formative research, the interviews and the surveys that we did with dental hygienists and dentists, we did ask them, were they having these conversations? And overwhelmingly, no. People were not discussing HPV-associated oropharyngeal cancer or vaccines in the practice. And one of the reasons for that was they didn't feel that they had enough knowledge and the information provided. So session 1 helps to cover that. But the big thing is, when do we do this in practice? Because workflows are already busy. We're already have a lot crammed into that 1 hour practice. So what we did is we identified key opportunities that they could bring it up within their workflow. One being at check-in with the parent, we're bringing the adolescent back, you're running through the scenario for that day, letting them know what's going to be done, updating health history potentially. That's when you could have that conversation. One thing that we're really trying to do is get this question on health histories. We did a scoping review of health histories that we could find online and found that overwhelmingly no one was asking these questions. So adding that to the health history and just making it a key part of the conversation that way. During the hygiene appointment, oftentimes the dentist will come in to do that exam. Or if you're doing a head and neck assessment and the parent is in the back, you could also ask that question. Or when the doctor comes in to do the exam as well. So what we did is we provided these trainings for our dental practices, and then we asked them to educate, recommend, and refer to eligible adolescents in their dental office and track those referrals. Next slide, please. So we don't expect everyone to be experts in the area, and I would argue that I am not an expert as well. But we want to provide our dental providers with information that they can use effectively within the practice. We want to give them enough information that they can feel comfortable, but we wanted to leave them with resources that they could keep in the practice, that they could or keep in their units or their office space, so that they could refer to in case they ever get stumped or they forget what they're going to say. So we don't expect them to memorize a script, and parents also aren't going to remember a verbal only conversation. So we built materials. So on the left-hand side of the slide here, this is a flip chart. The left portion of the picture is the patient facing side. The right hand of that graphic is the provider facing side. So it's a flip chart that sits in the unit with the graphic of the face pointing to the oropharyngeal cancer space, and then below there's um, the suggested timeline or recommendation for vaccination. That faces the provider, or sorry, the parent. And the other side are talking points, potential questions and responses that providers might come across. And you can see that they're broken down into educate, recommend, and refer. So depending on where they are in that conversation, that might help to spur a conversation or a discussion. We then developed in the middle a parent brochure. So this is written with accessible reading level. It covers the basics of HPV, the oral health connection, and what HPV vaccination does. So parents can take this home, and this can be something that maybe they don't say yes to wanting that referral today, but they can take it home and think about it, and have that ability to do a little work on them, look into the vaccine a little bit more on themselves. And then on the right, we developed a prescription pad. So this was a referral tool with information about local vaccine providers or where they could write local vaccine providers on there. So the idea behind the prescription pad was thinking about how traditional referrals are done within the dental practice, where you write out your referral form, you scan it into your EHR, you give it to the patient, and they can take that with them. One thing I don't have here is the vaccine provider documents. So in our more rural communities, there may not be primary care physicians in the area, but there may be community health clinics that provide vaccinations. So what we've done with the offices that we've worked with in our rural communities, if we've created a resource. So if we're in a practice, we'll give them a document that has all of the providers, pharmacies, and health clinics, and whether or not they're vaccine for children providers. If they are a VFC provider, they would provide the HPV vaccine at no cost, regardless of insurance coverage. So we have laid that out for them, and we give that to the dentist, hygienist, and assistants so that they can hand it out to parents if there's any uncertainty of where they would go. And we're hoping to build that into a website so it's much easier to adapt to the ever-growing changes within public health spaces. Next slide, please. So what happened when we put this into test? We piloted this with 2 practices here in the Johnson County, Iowa City area around the university. Clinic A was a much smaller clinic. Clinic A had around 78 eligible patients. So for our pilot project, we were targeting 9 to 17-year-olds. The idea was to have dental providers have conversations and provide referrals to parents of adolescents. So we weren't having the conversations with the adolescents themselves, but with the parents. And out of that, we had Clinic A, we had 78, and Clinic B, we had 439. Now, what you'll see is interesting here. We asked dental providers to track whether or not they educated, they recommended, or they referred. And you'll see that the numbers don't quite match up because they could have been in any category, which is why we pilot. And it was a great learning experience for us as researchers, going out and working with clinics and thinking through how would this actually work in practice. Of course, it got confusing. And with Clinic B, towards the end, they were just, if they provided a referral, they just coded it out as educated. We've since cleaned that up for the current project, And as of, I think, 2024, 2025, CDT, our dental billing codes, has a new code, D1301, which is for immunization counseling. And that's what we're having providers code out for if they are providing referrals. So it's a much easier for dental offices to use moving forward. Next slide, please. But what I do want to say is that these were touch points that uh, these were adolescents that had not had these conversations before. So we're still happy with what was being done at that time. I do want to talk. So prior to our Educate, Recommend, and Refer training, we did a pre-intervention survey where we asked our practices about knowledge and attitudes with HPV and whether or not they were having these discussions. Um, and what we saw is that knowledge about that HPV vaccines prevent OPC, we had 56% thought so before training and 82% after. But really what we saw is confidence, increased in confidence in wanting, in the ability to have these discussions. Next slide, please. Post intervention, we also interviewed them because we were our providers because we were really interested in getting that clinical feedback or that feedback from our clinical offices. And three things really stood out. Number one being the intervention was implemented without substantial changes to their clinical workflow. And that was key because to ask dental providers or dental offices to implement this, we needed it to not be disruptive to their already busy schedules and to be seamlessly integrated into their workflow. Number two, the the three distinctions, as I mentioned, coding out between education, recommendations, and referral was cumbersome. So that was extremely helpful. It was real world friction that we were able to modify and adapt for our current project. And then three, uh, one of my favorite things is that the staff kept telling us that parents were so receptive. I'll be honest, when I first approached these two practices or when they said that they would work with us and we were talking about what this would look like, there was some hesitancy from some of the providers. And about a check-in about halfway, that hesitancy disappeared. They were so happy with how parents responded. And parents are so receptive. That was a direct quote from our interviews. And providers reported that conversations got easier the more and more that they did it, as everything does. The more comfortable we feel with it, the more comfortable these conversations have. Next slide, please. So before the training, dental providers in our pilot reported no prior experience in educating parents with HPV. They had never done it before, but after training, those same providers were referring patients for the vaccine some or all of the time. So very positive. That to us, that behavior change is critical. Of course, we were excited and interested. We wanted to see that knowledge change too, but the behavior is really what we're interested in. Um, and that really shows that the training that we provide them, that knowledge foundation really mattered as it translated into action in the dental office. Next slide, please. So this slide's busy, but this is the current study that we have. The pilot data was compelling enough that we are now running a statewide intervention, and this is roughly what it looks like. I will say there's been some changes even since I gave Deborah the slides. But our goal is to work with 40 dental offices across the state of Iowa, and they are being recruited and randomized in two waves. The idea was to create, we split up the state. If we think of Iowa as a square, which we kind of are, we split the state up into quadrants and we randomized those quadrants where 10 offices would be our intervention clinics. They would do the pre-training survey, and we would collect EHR data. So asking them just sort of baseline how many adolescents do they see. They would receive the education recommendation and refer training. And then for 1 year, they would provide referrals and track referrals using that D1301 code. And then we would follow up with post-test survey, EHR data, determine how many referrals were provided. And we have four fidelity checks along the way to see, do we have new staff? Have they been integrated into the program? Because we're really looking at sustainability of this. And do we need increased education and touch points along the way? One thing that we are lucky to have in the state of Iowa is Immunization Registry Information System, or we call it IRIS. This is where we can, as providers, we can look up vaccination status of patients. Now, this is something new that we're adding to the project itself, is we're going to get dentists and hygienists onboarded with the program, and that'll also be a way in which they can evaluate and sort of track whether or not their vaccination conversations and referrals are meaningful, and that's something that they can look at themselves. Iowa, we also have access to that data. So what we're looking at is within those intervention quadrants and the comparison quadrants, what do the vaccination rates look like? Are we seeing increased vaccinations within those counties? Now, as I mentioned, there's been some changes. This project is CDC funded, and with changes with federal funding, we've sort of shifted a little bit on the model to where we are trying to educate as many as we can, but still tracking vaccination rates across the state. Um, so again, we started, this was a 5-year project. It is a 5-year project. We're in the second year currently. We just did our last round of recruitment. And we've expanded recruitment to not just rural. We were initially targeting rural clinics, but we've expanded to also urban areas. And we've been genuinely overwhelmed by the number of dental offices that have reached out asking to participate. Our initial run through, we had 10, I think 10 or 11 dental offices, but we have over 50 on the waiting list that want to participate. And this is where we're trying to identify, how can we bring them into the fold? How can we educate as much as we can, or as many as we can? We are looking at doing, currently training is in person, but we are expanding to also virtual models. And then a third arm being educating providers on the IRIS data where they can do additional vaccination screening there. So to bring it all back where we started, HPV-associated cancer is a growing problem, especially in the Midwest, especially for men. But we do have a vaccine that can help prevent that. Vaccination rates, at least in the state of Iowa, are backsliding, but we do think that dental teams are unique, trusted providers, and they're underused access points for adolescents that we may not be leveraging at fullest capacity. This is a chance for medical dental integration. It's a health service story about reaching patients where they are. And I'm generally grateful to be able to share this work with you. And I'd love to take any questions. I think, Deborah, that's the last slide that I have. And then I have a whole host of references, if anyone's interested in where we pulled that information. But thank you.
Thank you very much. I appreciate that. And there are a lot of references. So if someone wants a copy of this PowerPoint, you can contact the IOMC office, and we'll be more than happy to provide that to you. So I have a couple questions, but let's look at the questions that are in the Q&A box right now. Let's see. Is this happening in Chicago?
That's a great question. To my knowledge, no. I will say my dean at the College of Dentistry here was in Chicago for quite some time. I think they had a small project where they were talking about vaccination within orthodontist practices, but I think that was just a small little group, and I don't know that that's continuing.
Mhm.
But to my knowledge, I don't think anything's being done to this extent there. But again, I could be overlooking something.
So it's something that we can look into,
Mhm.
one way or the other. Okay. All right, here's another question. If you control for smoking and alcohol intake? Is there a predominance of men with still, if there's, is there still a predominance of men with oral cancer?
Yeah, that's a great question. Yes, there is. So the I work with individuals at the Iowa Cancer Registry and different cancer groups here within the state, and they have been looking at smoking and alcohol intake. Iowa is our latest report came out. We're one of the most predominant in binge drinking within the state itself. They have done a lot of work with that. And yes, we do still see the predominance of men with oral cancer once we control for those factors as well. That's a great question.
Mhm. Are there other factors that, and you mentioned some of them. What are the key factors that you feel that's contributing to this?
To oropharyngeal cancer specifically, or HPV associated oropharyngeal cancer?
Both of them.
So, good questions. Um, Within the state, we do have high rates of alcohol use. Um, I think it's also predicted by 2030 we will have the highest tobacco use
Um,
again. So we're seeing upward trends of tobacco use, which with the intake of those substances orally, that could increase the risk. Anytime that we are introducing different chemicals in the mouth, there's a risk for a change there. So thinking about oropharyngeal cancer specifically, we do also have the highest radon exposure in the country. So if we're thinking broader cancer, our agricultural chemical exposures in rural areas,
mm,
water quality could be another aspect of that. We have high nitrates. Also, some water areas are experiencing arsenic or have been found to have arsenic. Um, Rising obesity rates, that can also be an increased risk factor for cancer in general. And we're an aging population. So it's a multifactorial, I
mhm.
guess, situation. In terms of HPV associated oropharyngeal cancer, this is something that we're not quite sure of. Um, Again, infections are typically associated with sexual activity. Um, and I want to say HPV-associated oropharyngeal cancer is on the rise globally, so much so that the International Papillomavirus Symposium had a whole session last October on HPV-associated OPC in general. But there's not a clear answer as to why it's increasing so much, I guess, at least in the state of Iowa. You know,
Mhm.
oftentimes we look at behaviors and factors in play with surrounding states, and there's not a clear-cut answer, I guess I should say. Not
Okay.
a satisfying answer, at least.
Yeah, yeah, exactly. So what do you think will happen with as studies continue and or maybe they include this now in the smoking definition with vaping,
Mm,
with CBD, with TCH, and so all these other things that are now part of our, in some ways, mainstream society. It doesn't mean everyone's partaking, but they're certainly available, more readily available. I mean, we have retail stores and other, places in order to be able to provide these products. So, any prediction, or is there studies going to be addressing those areas as well?
yeah, I'm pretty sure there are studies that are currently undergoing looking at those. The challenge too with vapes, different products, ends and so forth is that they're not as regulated, so it could be
Sure.
difficult to understand what products are being put into the devices.
Mhm.
But I know that I'm trying to think. I know that there's a study currently being done looking at that. I think,
Mhm.
though, some of the challenge too is thinking like some of these will take years to progress and to
Correct.
identify.
Mhm.
Um, So yeah, there's work being done in that space. I will be honest, that's not necessarily my where I focus or my where I've worked in, I guess.
Mhm.
But yeah, I will be interested to see what role those play in
In the
cancer.
future, yeah, and
Yeah.
definitely in the future. So, tell us again then, what age is the ideal age to begin to get the vaccine?
Yeah. So they have the newest recommendation is starting the conversations at age 9.
Okay,
Um, age 9 to 14 is the ideal range. The vaccine dose is 2 doses under the age of 15. And then after the age of 15, it is 3 doses. And it's there are I think 6 months apart. So for the first
okay,
dose, it's 1 dose, and then 6 to 12 months later, it's the second dose. The
okay,
challenge, and one of the reasons why they want to have the conversation earlier, is if you have a parent, a immuno response, we respond better. Another reason is at age 9, there's less competing vaccines as well. Age
okay,
12 is a vaccine heavy time. And then starting those conversations earlier, if you have a parent who is hesitant, bridging the conversation at age 9, revisiting the conversation at age 10, you're much more likely to bring that individual into an understanding about the vaccine and initiating the vaccine prior to that 15-year period there.
okay, yeah. So now, what happens if you miss that age, that scale? I mean, is this something that an adult, should consider looking at having?
Yeah, so they do recommend it up until the age of 45. Insurance
Okay,
can be the limiting factor for some individuals. I want to say 1 dose is it's under $300, around 250 if you are in the adult range and the vaccine for children provider do not cover you. Most insurances cover it till the age of 26. I believe more and more are covering up until the age of 45. And I know there are studies being done for the 45 and older group as well. Again, it just takes time for efficacy and safety and sort of an understanding of how it works in those populations.
okay, all right, good. And so tell me again, when did the vaccine first started? When was it altogether?
Yep, so in 2006 was when the vaccine rolled
Six.
out.
Okay.
I want to say globally, but I know that I think a few countries were a year or two behind that, but that 2006 is the initial vaccine rollout.
hmm Okay. And are physicians also encouraging this?
Yeah, so physicians, pediatricians, anyone that does well-child visits, typically this would be part of the conversation. What we did find in our formative research is that not all primary care physicians, pediatricians were offering the vaccine, or when the vaccine initially rolled out, as I mentioned, it was for young females, typically targeted young females as a form of
hmm
cervical cancer prevention. So, and it wasn't a required vaccine. It's not necessarily a required vaccine. So, what we've heard and what we've seen from the literature is that some of those referrals may have not been strong referrals,
hmm
or there might have been hesitancy on providing the referrals. So, our goal is to, add an additional touch point with a dental provider to provide support for those pediatricians, primary care physicians who are also um, recommending and referring for the
hmm
vaccine.
Okay. Good. 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 All right. Are there any questions that we didn't ask that you'd like to highlight on from your presentation today?
Um, I guess the big thing that I don't know that I necessarily wanted to touch on, but with the vaccine itself, there's been no serious adverse effects since introduction of it in 2006. And, you know, oftentimes there's hesitancy
Sure.
uh, with are there additional concerns like safe with pregnancies or safe with fertilities? Again, no adverse effects that we've seen during those times. Another question that we often get is how long does the protection last? Do we need boosters? But so
Sure.
far, data has shown titers 14 plus years out. Immune
Okay.
response has still been sufficient. Again, science changes, things shift, but as of right now, it looks to be that if you are vaccinated, you don't necessarily need a booster.
Okay. Good, good, good. Excellent. Well, thank you very much. This was
Yes,
very
thank you.
informative and very interesting to see the results and also between Iowa and Illinois, what is happening or not, between the states as a whole. So thank you very much for your time and your expertise and keep at this because appears to be a very important area that we should be looking at altogether. So
Yes, thank
I would,
you.
yeah, absolutely. So I just want to make a few reminders here to everyone who is on this webinar. There will be a questionnaire to fill out after this session. And then there'll also be a survey to fill out after this. And those will be required in order for you to get your CEUs or CMEs credits itself. So we'll send that out to you today. And that will take care of that part of you getting your credit hours in themselves. Just wanted to remind everyone that this week is the final deadline for the leadership awards. So there's likely colleagues that you are doing admirable work and may not always be recognized for what they're doing. This is a great time in order to be able to do that. And you can submit that to IOMC online. The information is on our website. If you need any other information on it, feel free to call the office. We'll be glad to, help you locate that in the nomination form. We are very excited about our upcoming 2026 Leadership Awards and annual meeting with Dr. Sousa as our keynote speaker. It'll be a great way in order to meet him, to learn more about his background, what he intends to be doing with RFU, and also here in the state of Illinois, and strategic partnerships and other things that are available as well. Check out the Career Job Center. And thank you very much for joining us today. We appreciate everyone's time and effort, and we hope that you will attend future webinars. So thank you very much, Dr. Sokolsky. I want to give you one last thank you for a very robust and professional presentation, and certainly one that's needed by all of us to learn more about. We appreciate it. Thank you.